Hit the subscribe button or visit us at auau.auanet.org.
Thanks very much, everyone, for joining us for today's webinar, Perspectives on Increasing the Use of Palliative Care in Advanced Urologic Disease. This webinar is part 2 of the AUA's 2021 Quality Improvement Summit. I'm pleased to introduce the course directors for this webinar. Jonathan Bergman is an Associate Professor of Urology and Family Medicine and Associate Program Director at UCLA. As the Chief of Bioethics at the West LA VA and the Chair of the Urology Primary Care Work Group at LA County DHS, he has an interest in health systems, population health, and medical education. He also works on integrating palliative care into the management of urological patients to address the needs of patients with advanced disease. John Gore is a professor in the Department of Urology at the University of Washington School of Medicine and affiliate investigator at the Fred Hutchinson Cancer Research Center. He is program director for the University of Washington SUO Fellowship in Urologic Oncology. His clinical expertise is in urologic oncology, and his methodologic expertise is in health services research, including surgical outcomes research, patient-centered outcomes research, comparative effectiveness research, and quality of life. Next slide, please. Thanks. I'm pleased to introduce the faculty today. Further detailed introductions and biographies will follow accompanying their presentations. The faculty for today's webinar include Pauline Philippou, Joshua Hauser, Farnoosh Nikad, Lee Hugar, Kevin Koo, and Martha Terrace. Each speaker brings a unique perspective on how we can increase the use of palliative care in patients with advanced urologic diseases. At the conclusion of today's webinar, participants will be able to identify practice site clinical innovations in primary palliative care in urology, describe the clinical roles of various clinicians in the implementation of primary palliative care, and illustrate the perspectives of urologists at various stages of training regarding preparation for implementation of palliative care concepts in urologic practice. From here, I'm going to hand it over to Dr. Gore.
Good morning, everyone, and thank you for joining us today. We're really excited to welcome you to our second webinar that's focused on perspectives on palliative care and how we can increase use of palliative care in urology. We had an outstanding first webinar, and I hope we'll see as many of you as possible at our in-person summit that's going to be aligned with the in-person AUA. I have the distinct pleasure of welcoming Pauline Philippou to the webinar. Dr. Philippou completed medical school at UCSF and then completed her residency at the University of North Carolina, Chapel Hill. There she was honored with the Pope Clinical Trainee Award, which is typically given to medical oncologists, but her humanism and patient care was so outstanding that she was awarded as a urology resident. Dr. Philippou is currently the SUO Urologic Oncology Fellow at the University of Washington. She's the recipient of a Urology Care Foundation Research Award, and is currently completing both a certificate program in palliative care as well as a certificate program in teaching scholars at the University of Washington. Dr. Philippou is going to talk to us about an evidence synthesis she conducted on palliative care innovations in surgery. Thank you so much.
Thanks so much, Dr. Gore, for that kind introduction. And thank you also to Dr. Nielsen, Dr. Bergman, and to the AUA for not only including me in the seminar, but also for bringing this important topic to the forefront of conversations in our field. So last week, we heard from multiple leaders in our field in the previous webinar about different ideas of how we as urologists can incorporate primary palliative care into urology with the ultimate goal of improving value-based care delivery for our patients. And panelists really echoed the sentiments that earlier delivery of different palliative care skills by urologists can make a large difference in the care trajectory of our patients and their caregivers. And so I, like many of you, I'm sure that were in attendance, came away from the webinar energized and ready to implement primary palliative care skills. But delivery of primary palliative care is not easy. It's a deep skill that, like many skills, requires learning, training, practice, feedback, and development over time. And because we as a field are more recently determining the importance of this skill within our scope of practice, the skill development is not one that we've been prioritized in our education in med school, residency, and fellowship, or even in CME once we're practicing as urologists. So in realizing that the skill development of primary palliative care delivery is an important one, but one which we have not yet developed urology-specific interventions for, we look to the literature to determine how this skill development is being done in the surgical setting and if it's been successful previously. Our goal was to do a systematic review to characterize educational interventions that were aimed at improving primary palliative care delivery in surgical settings. So in order to do this, we used Medline and Embase to search for literature that described educational interventions which targeted surgical patients, families, caregivers, surgical healthcare providers, which included physicians, APPs, residents, medical students, nurses, and support staff. Interventions could be related to palliative care knowledge delivery, skill development, or the delivery in the surgical setting. And multitude of outcomes were included, including the delivery of primary palliative care consultation improvement, patient satisfaction, and healthcare quality indicators. The timing of included studies was from 1990 on, and this was because the first palliative care medical service was established in the late 1980s, thus including publications prior to this would not have been fruitful. So a total of 1,922 publications were queried and 24 met our inclusion criteria. You can see from the timeline that the majority of the publications were more recent. So 21 of the 24 studies were published from 2010 onward, with 63% of the included studies published since 2015, really highlighting more recent emphasis of the importance of this skill development in the surgical setting. Educational interventions mostly targeted resident surgeons. 14 of 24 studies targeted residents, and only one study included urology residents as part of their intervention cohort. This was followed in popularity by interventions that targeted medical students for a total of 4. And all 24 studies were descriptive of interventions that were performed at a single institution, so there was no cross-institutional collaboration. And interventions were developed within the institution that implemented and evaluated them. When we look into a little bit what types of interventions were implemented, there was really a large variety of different types of educational interventions. So when they targeted healthcare providers, workshops featured multiple pedagogical tools that were implemented and evaluated. And these included didactics, which included different forms of lecture-based instruction, small group work, and case-based learning. This often involves some level of pre-workshop work where providers pre-read or conducted board-style questions prior to the intervention to assess baseline knowledge. Some didactics were done for a very different amount of intensity of hours. So some had just 1 to 2 hours of intervention. Others were done over several months over the course of a curriculum type implementation. That really highlighted the variability of instruction intensity. Web modules were used to provide electronic didactic intervention, and 38% of studies had portions which included simulation in the form of role plays. The majority of the interventions included some form of this. And these simulations usually focused on skill development, where patients and providers displayed exemplary communication skills through videos or through live role play. OSCE, the objective structured clinical examination, was used, where residents and medical students were observed and evaluated on skill demonstration and then given feedback in terms of how they performed. And there was a small amount of studies that targeted patients, surgical patients specifically, and these studies described the use of scripted tools, storyboards, or video modules to acclimate patients to different aspects of palliative care. So in regards to the different domains of palliative care addressed, there's a total of 8 described domains. 6 of the 8, which are highlighted, were addressed by interventions described by the publications. As you can see, 2 domains were not specifically addressed, and these included the spiritual, religious, and existential aspects of care and the cultural aspects of care. And within these domains, a variety of different skills were addressed. So this diagram highlights some of the many skills within each domain, which was addressed through the educational interventions. And I'll just highlight a couple. So in the upper right-hand corner, the structure and process of care domain, this included interventions targeting general knowledge of palliative care services, code status discussion, informed consent, and hospice referral. And 3 different studies focused on implementing an informed consent skill entitled Best Case, Worst Case Scenario, which is a value-based informed consent framework that providers can use with patients and their families. The most frequently addressed domain was social aspects of care, particularly communication skills. So 15 studies, or 63% of those included, focused on assessing, developing, and evaluating communication skills, which included prognosis discussion and disclosure of complications, particularly in the context of running family meetings. And then finally, 7 studies, or 30% of the included studies, address skills facilitating advanced care planning. So you can see the large variety of educational implementation that's already been done addressing these different palliative care domains. The different outcomes that were examined included how the intervention affected the provider or patient attitude and receptivity to palliative care, included knowledge improvement surrounding palliative care services, and the value of these interventions to the patients or providers that were undergoing the intervention. And interestingly, 100% of interventions, no matter how they were structured or for what time intensity, found improvement in these 3 domains when they were assessed as part of the intervention. Additional outcomes that included confidence in the skill that was being targeted, as well as whether or not the skill had demonstrated improvement following the intervention, were also, in the majority of the interventions, successful. So in conclusion, an excellent starting point has already been developed within the surgical field of ways that targeted interventions can be implemented to improve skills and barriers associated with delivery of primary palliative care. Medical students and residents, as we saw, have mostly been targeted with these interventions, and there's been a relative lack of studies that target either practicing providers, ancillary staff, or patients. So I think the upcoming discussion with a deep dive into the different barriers that providers at all stages of our field encounter in implementing palliative care is going to be really important to take into account. And this framework is going to be vital to determining what barriers we can target in urology and how we can build on existing interventions to improve the palliative care delivery in our field. So thank you so much, and I'm more than happy to take any questions.
Thank you so much, Dr. Philippou. We're just waiting for any questions anyone may have in the chat box. What was interesting to me is that, today we're going to gather up perspectives of, varying levels of training from resident to fellow to attending to more senior attending. And I think that's going to highlight, what you just showed and how this was assembled. As we think about training a population of urologists, how does that fit with sort of these role-playing concepts for how to train individuals on delivering primary palliative care?
Yeah, I think systematic kind of widespread implementation is going to be really important. I think role play as a tool in order to do that is also going to be really important, as I think without the demonstration of clear exemplary skill delivery, there's not going to be an easy way to kind of base learning off of how we want to try to achieve to do things. So I think it's going to be difficult. It's going to be a lot of work, but I think it's going to be worth it.
So how do you create a big enough population of trainers that you can disseminate this? Because, right, if you're doing it role play based, it has to have a trained observer who understands how to intervene and reshape, the conversation to make it an educational tool. So how do we do that as a field?
Yeah, I think having several, pre-done or pre-recorded videos that we could use as our kind of exemplary model to then disseminate and be able to train people interested in training others through that could be helpful. I think several of the studies that were included actually already had kind of, training framework things laid out that they then distributed to the people who were implementing the workshops within their institution. So certainly something that we could build off of and wouldn't have to make from scratch, particularly with the best case, worst case scenario that was studied in 3 of the studies. They already have a video online that you can access. They have a workshop training, outline of what can be done to train trainers. So we wouldn't have to be starting from the beginning.
So this is a question that I think also harkens back to webinar number 1. And this is a question from our audience, and it's what makes you or the panel feel that this is a need in urology? I think what we gathered from the previous webinar is, various disciplines, oncology, endourology, female pelvic medicine, and reconstructive surgery, they all highlighted really illustrative examples of why this is needed in urology. But do you mind sharing your perspective on why this is a need?
Yeah, I think at the end of the day, palliative care is really a patient and family value-based mode of delivering care to improve quality of life. And I think in some ways we're all doing this in our daily life already, but to do this effectively, particularly in more difficult situations that we all as a field encounter, takes skill. And when it's done well, it's shown to have benefit to our patients and their families. And so I think because it hasn't been previously targeted as a skill development that we should be focusing on, expecting people to just know how to do it well is not reasonable. I think it has to be kind of focused on and taught, essentially.
Yeah, and I think what the examples in the previous webinar showed is that, we have a number of patients that have, care needs toward the end of life that interface quite extensively with our urological care, and we confront an immense palliative care shortage. And so it's not that we have the ability to just, refer these patients for outpatient palliative care. So that was another thing that was a big take home for me in webinar number 1.
Yeah, absolutely.
Any other questions for Dr. Philippou? All right, I'm going to hand this over to Dr. Bergman to introduce our next speaker.
I think before I introduce our panel, I just have to congratulate Dr. Philippou, not only on her ideas, but on actually how much work she's already been able to do and how much she's already moved the needle forward in such a short amount of time. I was trained operationally partly by Mitch Katz, who runs our county system, and he always talks about 5% of something great being the idea and 95% actually the work of getting it done. And I'm so impressed by how much Dr. Philippou has already achieved in the last short little while. And it's super exciting to think how much we can all do together in the coming months and years. So Dr. Philippou does a great talk and amazing work so far. We're now going to introduce our panel. We're super excited to have them all. We're going to introduce them one by one, and I'm going to start by introducing Dr. Hauser. We are super honored to have him join us today. Dr. Hauser got his MD at Harvard before doing his residency at Brigham and Women's in internal medicine, followed by a fellowship at the University of Chicago. He's currently at Northwestern, where he's an associate professor of medicine and medical education, and also the director of the Palliative Medicine Fellowship. He's one of the only people in the country who's certified in both internal medicine and hospice and palliative medicine. And he has a busy clinical practice both at Northwestern and at the VA. Dr. Hauser is the director of EPIC, which is Education on Palliative End-of-Life Care, which is the premier educational program about palliative care. It's very robust. It's been multiple times funded by the NIH, and it actually was very prominent in crafting the Institute of Medicine's 2015 report, Dying in America. Dr. Hauser is also the past chair of NIH study section on research ethics, and he holds more positions in palliative care than we have time to list, and he's done more meaningful research in the field than almost anybody around, and we're super honored to have him join us today. Outside of work, Dr. Hauser is into 1980s punk indie music, including Husker Du, The Replacements, Wire, and Big Star. Dr. Hauser, thank you for joining us.
Dr. Bergman, or John, as I've come to know you, thank you for that introduction. And I'm really just, it's a privilege to get to be here and spend time with you and others in the urology community. I appreciate your saying that EPIC is the premier education project. I think we are one of many. And one that I'm very proud of, and I'll talk a little bit about that in a moment. But I want to emphasize that we are definitely one of many, and it's a really important field. I also want to thank Caitlin and many others at the AUA for their helping coordinate this, and echo what John just said about Dr. Philipou's synthesis of the literature in this area. Really important stuff. So thank you for doing that. So I want to start with a case, if you will. A patient asked me one time, shouldn't you be extinct? This was when I first was starting in palliative care. As John mentioned, I'm an internist and also a palliative care physician. And she further expanded that question to say, isn't this, helping take care of patients with serious and life-threatening illness, what all doctors do? And then she said with a little bit of a twinkle in her eye, or should do. And it brought up to me questions of what does it mean to be a specialty and why do we need another specialty called palliative care? And the question which you guys are considering, and I imagine came up last Saturday, and I apologize that I wasn't able to be here last Saturday, but you guys are considering, which is what does it mean to do primary palliative care versus tertiary or specialty palliative care? So I want to go over that distinction for a moment. I will make the case, as others have, that the reason we need another specialty is because there are things that are unique to palliative care physicians around experience, around expertise, and even around time. I think it's important to acknowledge that a palliative care physician may have more time for certain things than a urologist. And by the way, a urologist may have more time for certain things than a palliative care physician, and certainly more expertise in certain things than a palliative care physician. So, sorry, there's a little bit of a lag in my slide. I should be used to that. I apologize. This is an article which may have come up last week, but is this generalist plus specialist palliative care creating a more sustainable model from Timothy Quill and Amy Abernethy, who are two leaders in our field. And what Tim Quill and Amy Abernethy talked about was this distinction between primary palliative care, in other words, the skill sets that we want all clinicians, urologists, cardiologists, oncologists, emergency medicine physicians, et cetera, to have. And you can see examples of those there. And then the skills that a specialist in palliative care, someone like me or colleagues whom I work with might have. And you can see examples of those there. One that is not on this list, but was talked about in Tim Quill's and Amy Abernethy's article is the topic of training other folks, other urologists, other colleagues in this area as an element for, we hope, specialty palliative care and for our field in general. So you can see in this conceptual model, refractory symptoms, more complex psychological states, assistance with conflict resolution and more difficult communication skills are really the domains of specialty palliative care. It was interesting to me to learn just a few moments ago from Dr. Philipou's review that some of the topics of spirituality and cultural issues are less frequently talked about in some of these primary palliative care interventions. And I think that makes sense, but might be an area for growth for all of us. So there might be a couple modes of integrating urologic care and palliative care. One is there's specialty palliative care where all patients with disease or disease state XYZ get a palliative care consult. And then there might be a primary palliative care model where all urologists, and when I say all, I mean a subset or a good number or some number of team members or teammates, which brings up the issue that Dr. Gore brought up about how to sustain such a training. All urologists get palliative care specific training in topics A, B, and C. And I have in brackets there EPIC neurology, and I just want to talk for a moment about one of our projects with the EPIC program that I direct that's underway with colleagues who are neurologists. Now, we in EPIC are devoted to trying to integrate with any number of medical, surgical, and other subspecialties. And a few years ago, a colleague, kind of like Dr. Bergman approached me, but a colleague approached me in neurology and said, we want to work around training neurologists in palliative care, specifically neurologists who care for patients with advanced Parkinson's disease. And so Benzie Kluger is running a randomized trial of usual care for patients with advanced Parkinson's disease versus usual care plus primary palliative care. And there are three aspects of this intervention that might be relevant to urologists. So the first element is that we have a day-long training using EPIC-based materials adapted for neurology. The second element is that there are online resources, different kinds of handouts, prognostic scales, et cetera, for neurologists. And the third element is that there's an aspect of longitudinal coaching and mentoring. And the outcomes in this trial are looking at quality of life, symptoms, hospice referrals, and even length of life. As this audience may know, one of the foundational studies in this area is Jennifer Temmel's study, which showed that the provision of palliative care for patients with lung cancer actually had not just quality of life benefits, but length of life benefits. And there may well be blends of the above two kinds of ways of integrating. Now, just a word about EPIC, because that's an example of a primary palliative care intervention or educational program. This is just a screenshot from our website illustrating that we have a core adult curriculum, but then also have adaptations focusing on emergency medicine, pediatrics, the care of veterans, which is where I spend a lot of my clinical time, a program for family caregivers with some education about what they might think of around serious illness. And then, as I mentioned, a neurology project that's underway. And I've actually been working recently with a general surgeon on some work around palliative care for general surgery patients. These are examples of types of topics, and Dr. Philippou went through the domains of palliative care, so I won't repeat that, but just to say, this is just a piece of a screenshot where you can see the types of topics that our curriculum approaches. In the EPIC curriculum, we have modules, which are text-based materials. We have slides, which are freely adaptable once people become trainers. And we also have videos that can form the basis of role plays for each of our different curricula. So I want to end, and I hope some of this can come up in the discussion, and I imagine in the presentations of other colleagues, with a few kind of questions for us to think about as this integration is established. So one is the role of non-physician teammates. This is a vital area in palliative care, and I know urology, and it's an important area of education as we think about rolling out this kind of a program. I wonder, and John talked about this when he and I had a conversation a couple weeks ago about what we can learn from multidisciplinary cancer clinics in urology that might be relevant for palliative care in urology. And an interesting, more conceptual topic, but ultimately a practical topic, which is, will specialty palliative care, or does specialty palliative care either encourage or discourage primary palliative care? That's relevant to a model where all patients get a palliative care consult, for example. And finally, and you heard some outcomes for the program in neurology, what are meaningful outcomes for an integration of palliative care and urology? I'm going to end there, and again, thank John and others for inviting me, and for everybody to take the time to think about these important topics together. Thank you.
Thank you so much, Dr. Hauser. We are going to have all of our panelists at the end join to consolidate all the questions at the end. So we're going to gather all of these various perspectives, and we'll have a great panel discussion after that. I have the pleasure of introducing Dr. Farnoosh Nick-Ad. I met Dr. Nick-Ad, as many of us meet current residents while she was interviewing for residency. She is currently a resident in urology at UCSF, but before that, I was an undergraduate and medical student at UCLA. In between, she had a unique experience working for the coroner in Contra Costa County, where she identified problems related to the prevalent opioid epidemic and patients dying of opioid overdoses. One thing that I think about when I think about Dr. Nick-Ad was a quote that she shared with us when she was interviewing at the University of Washington. And I'm going to badly paraphrase that quote, but she basically told us, if I am true to myself, it does not matter if I'm afraid, which I think is very indicative of who she is as a care provider. So thank you so much, Dr. Nick-Ad, for joining us today.
Thank you so much, Dr. Gore. I'm glad you remember that quote. It is one of my favorites. So thank you so much, and thank you, Dr. Bergman. Dr. Bergman was actually one of my first mentors in urology, and is one of the reasons that I went into urology. So it's my pleasure and honor to be here today and to share the resident perspective on implementing palliative care in urology training. So when I think about my own journey to urology and the conversations I've had with my co-residents and attendings, I think many of us were drawn to urology, not only because of the surgical aspect, but because we address the full spectrum of disease, from malignancies to benign but chronic conditions. And we get to build long-term relationships with our patients and want to help address quality of life issues. Thus, the fundamental principles of palliative care tie in really nicely with our field. As residents, we are exposed to patients with palliative care needs at all levels of training, really starting from intern year. And I think that our residency training gives us significant exposure to several key aspects of palliative care. Specifically, one of the areas that we as residents have the most exposure to is delivering bad news, particularly when it comes to new cancer diagnoses. We address this both in the clinic and when we have consults from other fields. And we're often the first line when it comes to informing the patient and their family of the diagnosis and discussing treatment options. Along those lines, we also routinely address quality of life issues and goals of care, and often across all ages, whether it's talking to parents of children with spina bifida, addressing stones in patients with spinal cord injuries, or thinking about how to best help older adults with incontinence. From early on in our training, we begin initiating complex discussions with our patients and their families, and often encounter patients with numerous significant comorbidities that we take into account in our clinical decision-making. Quality of life is often at the forefront when deciding whether to do a procedure on a patient or when not to do a procedure on a particular patient. Along with quality of life issues, symptom management is a regular aspect of our training. For example, whether we're focusing on treatments for BPH and LUTS, or addressing urinary issues in patients with metastatic prostate cancer, where we're no longer managing their cancer, but can improve their daily function. So while these are some of the strengths to our training, there are also some barriers that we as residents face in terms of acquiring more knowledge about how to best implement palliative care in our practice. So when thinking about the challenges we face in terms of gaining a deeper understanding of palliative care, there are both some patient-specific and institutional challenges and some residency-specific challenges. One of the patient-specific aspects that we have less formalized training in is how to address the psychosocial needs of our patients. On an institutional level, we often, and very rightfully so, rely on multidisciplinary care, particularly with help from palliative care specialists. However, since we as residents are often operating during the day, we may be unable to be physically present to learn from the interactions between palliative care specialists and our patients, particularly as it pertains to complex psychosocial issues such as stress and hardship associated with disease or complex pain management issues. So we don't get to see how these assessments and conversations are approached. On the flip side, residency-specific barriers include an overall paucity of information on palliative care specifically tailored to urologists, facing increased time demands during the training process, overall resident comfort level with navigating difficult conversations and challenging interactions with patients and families, and a lack of a dedicated curriculum specifically on how to implement palliative care in urology. So to address some of these barriers, I think there are several aspects of training that can be expanded upon to better prepare us to incorporate palliative care into our own practices, regardless of what subspecialty we enter. One aspect is implementing immersive palliative care training aimed at teaching residents new skills in a structured setting. One starting point may be to specifically identify palliative care competencies for residents at each level of training, so that similar to how our surgical training is approached, there's graded responsibility and exposure. In addition, having communication skills workshops, particularly around goals of care conversations and how to help patients navigate challenging diagnoses may be another area to help increase resident confidence and competence. And finally, having standardized competencies may help focus future didactic sessions so that specific skills are being worked towards. When looking at the literature on teaching palliative care in surgical programs, there are several tools that have been employed by general surgery residency programs that may also be useful in urology residency programs. These strategies include incorporating palliative care into morbidity and mortality conferences and tumor board conferences, discussing end-of-life care for all deaths and palliation for major oncologic procedures, providing quick reference cards for communication phrases and pain management strategies to residents, and inviting residents to be members of institutional bioethics teams. Given the inherent intersection between urology and palliative care, I think we as urologists and urology residents in particular have a unique opportunity here to grow and further develop aspects of our training that will help us better care for our future patients, particularly as the population we serve gets older and will have more complex needs. So with that, thank you everyone for your time and attention, and I'll hand it back over so we can hear from our other panelists.
Dr. Nagat, that was incredible. You, from the first time I met you when you were, I think, a first-year med student, you've always been so wise beyond your years and poised and substantive and brilliant. And ever since you left us to UCSF, we miss you constantly, but we're so excited to get on work, to get to work on this together. So congratulations on a great talk, and we look forward to working on it together. Our next panelist is going to be Dr. Huger. Lee Huger did his undergrad at Penn State University before going to Emory for med school, and then residency at the University of Pittsburgh. He's currently a Society of Urologic Oncology Fellow at Moffitt. He has a background in health services research and has actually done, he's one of the only urologists who's actually done work in palliative care, and he's done really brilliant work in palliative care. And when we kind of think of who is the group that's going to take us from talking about this in a webinar and actually implementing something meaningful in our field, I can't think of anybody who's better positioned to do that than Dr. Huger. Dr. Huger does have a brand new son named Ryan. Good choice. That's the name of my son too. Little baby Ryan's been on many of our webinar planning Zooms, and I can vouch that he's super adorable. He also has a 7-foot alligator living in his backyard. So if he gives you anything prescriptive, before you decide how much weight to give his words, consider the fact that his judgment is such that he is growing a 7-foot alligator right alongside his brand new baby. Floor is yours.
Thank you so much, Dr. Bergman. That was a really generous introduction. So I'm going to discuss barriers to incorporating palliative care and some potential solutions from both provider and patient standpoint. So just a few provider-related barriers include communication skills training, emotional resilience, symptom management skills, prognostic uncertainty, and the surgical mindset in general. Communication and palliative care training is severely lacking, as we all know. A 2018 study from the journal Surgery showed that surgeons receive an average of 10 hours of palliative care education, compared to 30 hours for oncologists and 50 for intensivists. The authors of this study also provided participants with 4 clinical vignettes of complex patients to assess the aggressiveness of their interventions. 25% of surgeons in the study reported having received no palliative care training, and this group actually had the highest aggressive intervention rate. Emotional resilience should also be considered if a concerted effort is placed into having difficult conversations. From my own research experience conducting patient and caregiver interviews regarding palliative care, conversations about prognosis and end of life can be very emotionally draining at first. Also, responding to patient emotions is crucial in meeting patients and caregivers where they are and assuring that all issues are addressed before moving on to additional information disclosure or decision making. Two clinical barriers include inadequate experience with symptom management and advanced symptom planning, and prognostic uncertainty. So as urologists, we're used to managing urologic symptoms and acute inpatient issues like postoperative pain, gastrointestinal issues, or optimizing nutrition. However, we have very little experience in guidance in managing other common symptoms that hugely impact quality of life, such as depression, anxiety, chronic pain, fatigue, and anorexia. Providing patients with accurate prognosis is helpful for both surgeon and patient decision-making, but is a notoriously difficult task. Categorical predictions are accurate only a quarter to 3/4 of the time. And when numeric estimates are used, they're off by usually 3 months either way. What seems to be most accurate in terms of providing patients their prognosis based on a systematic review of the subject are probabilistic estimates using multivariable models. Finally, while our surgical mindset allows us to perform and problem solve in ways very specific and important to our profession as urologists, some aspects may prohibit thinking in a palliative mindset. Some of these traits include a great sense of personal responsibility, perceiving adverse events as personal failures. Some quality indicators actually may provide perverse incentives that discourage palliative care use. And in oncology in particular, there's an intense focus on cure, sometimes at the expense of quality of life. So I'd like to touch on some ways we can address these provider-related barriers and better incorporate palliative care skills into our clinical practice. Palliative care education is primarily communication skills training, in my belief. There are many excellent resources to improve communication skills. Shown here below is an app from VitalTalk, which is an organization dedicated to advancing communication skills. At the top right, I also find this pie metaphor extremely useful since patients and caregivers conflate hospice and palliative care. I emphasize to patients that hospice is but a slice of palliative care limited to a small group of patients at the end of life, whereas palliative care applies to all patients regardless of prognosis. In order to improve communication skills, particularly when delivering bad news, emotional intelligence has to be optimized. This book was written by the creators of the VitalTalk curriculum and provides a number of talking maps to help attend to patient and caregiver emotional needs. These often help the physician get to the heart of what is really most important and of biggest concern to the patient and their family. Recognizing and responding to emotion also assures that you don't forge ahead with your goals for the visit without first responding to all of the patient and family's concerns. How to operationalize better symptom management is beyond my experience and the scope of the talk, although we do touch on it. But those interested in building their supportive care repertoire can refer to the American College of Surgeons Palliative Care Curriculum, the European Urologic Association Pain Management and Palliative Care Guideline, as well as the NCCN Palliative Care Guideline. And as mentioned earlier, probabilistic estimates of prognosis outperform subjective assessments by the provider. This graph in the middle is work from Moffitt that I'm finishing up with my mentor, Philip Spies. We developed and validated a predictive model for overall survival less than 6 months following lymph node dissection for penile cancer. We were able to dichotomize patients into risk groups for limited overall survival less than 6 months. So the red line shows a median overall survival of 24 months for those at highest risk of limited survival compared to 174-month median overall survival for those at low risk. So we feel that similar research can streamline early palliative care referral for certain patients based on adverse pathology. These are 3 ideas that could increase the profile of palliative care among practicing surgeons and trainees alike. I think it's important to intentionally build relationships with the palliative care teams at our institutions. There's the potential for adding refractory or complex symptom patients to our tumor board discussions. And finally, emphasizing the role of advanced care planning or limited prognosis at morbidity and mortality conference when appropriate can help stimulate some interesting conversations. When it comes to emphasizing the importance of communication skills, Jeffrey Dunn, who is a general surgeon and founder one of the founders of the surgical palliative care movement, compares delivering bad news to performing an invasive procedure. He states that it is very obvious to anyone who's been on either end of it that disclosure of bad news is an invasive procedure. Invasive in the sense that once it's been delivered, the person's life will change forever. Dunn also emphasizes the similarities between the basics of good surgery and good communication. For both, you need experience and courage, good organization skills, a good assistant to help attend to patients' emotions and your responses, and finally, the proper setting to conduct these conversations. So it's also important to understand patient barriers if we want to improve incorporation of these aspects into our care. Studies have shown that only 30% of US adults have heard of palliative care. And among that 30%, half of them hold misperceptions of what palliative care actually is. Reported barriers to palliative care use among patients surveyed at oncology clinics include a lack of referral, a lack of their own awareness, and other logistical concerns. Finally, burdening patients with additional medical appointments may limit the attractiveness of outpatient palliative care. So how can we address some of these patient barriers? As mentioned, improved provider communication skills, especially some of the ideas that Dr. Nikad discussed earlier will be extremely impactful. Increasing access to educational resources, of which there are many, will allow interested patients to learn more about how palliative care may benefit patients and their families. And finally, exposure and access to palliative care will reinforce its positive attributes. Personally, we can increase awareness by improving our primary palliative care skills, as discussed in last week's webinar, and via interventions that Dr. Philippou mentioned earlier. Finally, practices can increase use by co-locating palliative care within outpatient clinics, which has actually been shown to significantly increase palliative care uptake. Thank you very much.
Thank you so much, Dr. Huger. That was wonderful. We have 2 more talks before we'll have our panel discussion, but we already have some really fantastic questions. So keep sending those in. Thank you so much. I have the pleasure of introducing Dr. Kevin Koo, who is currently an assistant professor in urology at the Mayo Clinic. I first met Dr. Koo at Dartmouth, where he was a urology resident. And prior to that, he was a medical student at Yale School of Medicine. He did an endourology fellowship at Johns Hopkins and is at Mayo currently. He has a number of incredible roles already, even as a junior faculty. He completed the Holtzcrew Legislative Fellowship from the AUA and currently is on the board of the AUA PAC. And I'm delighted to hear what Dr. Koo has to say about his perspective related to palliative care. Thank you so much, Dr. Koo.
Thank you, Dr. Gore. Good afternoon. And thank you especially to everyone who has joined us today, in particular, the trainees and early career urologists. I hope that our discussion meaningfully recognizes the considerable challenges and barriers you may face in integrating palliative care in your practice. I also hope that this QI Summit and the diverse perspectives we bring to it can enhance your ability to implement effective and practical strategies to prioritize your patient's quality of life. Let's start by acknowledging that your first faculty job seems like it should feel like this. After scaling the mountains of training, you have finally reached the summit and can look around. But maybe the reality is that it feels more like this. There are still barriers to overcome, and perhaps you, like me, sometimes feel like you're surrounded by ongoing challenges. And from time to time, let's be honest, being a junior faculty member might feel like this, and all you can do is hang on tight and not look down. The reason I mention all of this is because a lot of our discussion so far has been focused on evidence, application, the nuts and bolts of palliative care. But the demands on junior faculty are numerous and diverse. from setting up your clinical practice, to managing your day-to-day schedule and logistics, to arranging your burgeoning research program, to making sure you're an effective teacher, focusing on your professional development, and yes, even your self-worth. And all of these may manifest as both clinical and practical barriers to enhancing the use of palliative care in urology. So in this context, I'd like to suggest that integrating palliative care principles in an early career practice may be enhanced by 3 overlapping strategies: elevating quality of life considerations, empowering your care team, and recognizing the pressure to operate. First, let's think about elevating quality of life considerations and conversations. We've already discussed today how palliative care encompasses more than just end-of-life care, so we can similarly expand our use of these principles to include quality of life, which is relevant for every urological condition. But if you practice in a tertiary or academic medical center like I do, it's important to recognize our potential biases, to always want to do something or offer something to our patients. The patients who are referred to us or who come to see us may come with their own expectations from their families or their local clinicians that we will offer them 3rd line, 4th line, 5th line surgical or advanced treatment options that may or may not be aligned with their own interests. But I would suggest that by enabling patient education and routine counseling about quality of life for both cancer and non-cancer conditions, we can help our patients understand that palliative care options may in fact be their most preferred option. And we may be able to relieve their anxiety about feeling compelled to receive more aggressive care than they might otherwise want. Second, empowering your care team can help facilitate high quality, consistent palliative care. In a primary palliative care model like the one that we've been discussing today, it's important to think about who will oversee these complex palliative care management plans. Recognizing that palliative care involves a holistic approach to symptom relief and goal setting helps ensure that a patient's medical and psychosocial needs are adequately and effectively addressed. So, as you start out in your practice, will you have a dedicated APP or nurse coordinating these management plans? Or is your clinic part of a multidisciplinary clinic or program that focuses and integrates palliative care principles? In addition, you may want to partner in creative ways with junior faculty palliative care specialists. For instance, I've had good success reaching out to my palliative care colleagues who are eager to build their own practices and develop collaborative clinical efforts. You may also want to consider obtaining additional support or training resources for the members of your care team to ensure that everyone feels comfortable in their roles with regard to palliative care and is aligned with the same palliative care principles that maximize quality of life. Finally, as junior faculty, we must recognize the often unspoken pressure to operate. Because the reality is that we have undergone many years of intensive training to become surgical experts. So naturally, we may equate surgical volume with overcoming a learning curve and achieving skill preservation. So it seems logical to think that there will be negative perceptions of your clinical productivity and your surgical expertise if you don't offer surgery to every patient you see. And of course, there are reasonable considerations surrounding productivity, volume-based compensation metrics, and efficient OR resource use. These pressures are valid. It's important to recognize that they are, and they're important to consider. And I've had several honest conversations with my department leaders and senior colleagues about them, and I encourage you to do the same throughout the phase of building your early career. But I might suggest that when the pressure to operate dominates our decisions about building our early practices, It can adversely impact our ability to prioritize shared decision-making and quality of life. So instead, I would suggest that optimizing palliative care in your early practice puts the needs of the patient first, and it benefits your surgical volume and your clinical outcomes, which, if we take a step back, is what ultimately matters to your reputation and your confidence. I've discovered as a junior faculty member that my perception of what is important to my department or my colleagues is sometimes a bit skewed or unrealistic. And so having these candid conversations periodically as you develop your practice can help to reassure you and your colleagues that your shared priorities are in fact aligned. So by elevating quality of life conversations, by empowering our care teams, and by recognizing and acknowledging pressures that may or may not be realistic, we can each lead a team-based approach to primary palliative care in urology. This team and this patient-centered care approach is at the heart of the strategies we've explored today and should serve as the foundation of integrating palliative care principles in your junior faculty practice. I hope that these strategies can help each of us navigate the many demands on junior faculty, and in so doing, optimize the quality of life of our patients and ourselves. Thank you for your participation and your dedication to quality improvement.
Dr. Koo, that was awesome in a word. I think that picture you have of climbing the mountain and then hanging off the cliff, you should show at the Mayo graduation this year so that all the people who are graduating and feeling super excited that they've climbed the mountain realize that they have a hot 20 minutes to enjoy it before they're hanging on for dear life by their fingernail. I was also struck by what you said about how much time we put into learning about and studying and evaluating, fifth line therapies for certain conditions, and how much robust data we have about all of those fifth line treatments and how little we have about palliative care, which really, I think, highlights how exciting it is that we have this opportunity to try to build that out a little and try to learn a little bit about as much about palliative care as we know about our fifth line therapies. So thank you for all your work, and we can't wait to work on the next steps together. It's now my honor to introduce Dr. Martha Terrace. Dr. Terrace got her MD at the University of Mississippi before going on to residency training at Duke for general surgery and then Stanford for urology. She stayed at Stanford for her oncology fellowship and then was recruited to stay on as the chief of the VA. She then was recruited to the Medical College of Georgia and the Augusta VA. She was the program director in addition to having many other roles. She's currently the chair of urology, and she's also a trustee at the ABU. Dr. Terrace was actually a DJ before she started med school, and her specialty as a DJ is 80s rock and roll. So Dr. Hauser, I'm sure she has some Husker Du and replacements in her repertoire that maybe she'll show off at the September meeting of the AUA. Dr. Terrace's current favorite hobby is making urology-themed TikToks with her residents. So for all of the people on this call who are young enough to actually have TikTok, check out @Martha Terrace, and she has some really cool videos up with her residents. Dr. Terrace, it's an honor having you with us.
I've been tasked with talking about how senior faculty think about palliative I've been tasked with talking about how senior faculty think about palliative care and how we introduce senior faculty into accepting palliative care as an option for our patients. Our generation has not often thought as palliative care as something we as urologists do. We did not have training in this during residency. We don't really consider it often unless the patient mentions it. And usually when the topic does come up, the knee-jerk reaction is to refer that patient to social work or back to their primary care or to their medical oncologist to take care of setting up their palliative care plan. In addition, you've got a fairly elderly population of urologists here who really don't want to talk about people getting older, people not being able to take care of themselves, because there's an element of job insecurity associated with admitting that we're getting older and not able to do what we used to. And they don't consider palliative care to really be part of urology. There's certainly longstanding medical and cultural beliefs that palliative care or not being aggressive, taking care of whatever ailment a patient has is a professional failure. You didn't do your job. You're not taking good care of the patient. There's certainly economic incentives to actually doing more procedures or doing more interventions on patients that they may or may not need. There's fear of litigation. If you choose not to intervene on a problem, then could that patient come back and sue you or the patient's family? Certainly our generation feels like there's more difficulty prescribing pain medication. We practiced in the day where you give away buckets of pain medication. And of course, now we've learned that that was the wrong thing to do. But the limitations now on prescribing narcotics and other pain medications is intimidating to a lot of more senior faculty. And again, lack of palliative care communication training and lack of awareness of the options is a big issue. So when addressing this with senior faculty, one point you have to make is that palliative care isn't hospice. It's not consigning the patient to death. It just means that we're not going to be aggressive, taking care of what their urologic options are. And they're usually already doing this. You have to capitalize on that, whether it's a chronic catheter or a diaper for a frail patient that has bladder dysfunction or chronic retention, whether it's chronic stents or nephrostomy tubes for malignant obstruction, or whether we should even do that at all. Watchful waiting for prostate cancer, small renal masses, non-obstructing lower pole stones. All of these, we probably have examples in our practice of when we have chosen the less aggressive option for patients. So capitalizing on those situations and calling that palliative care, putting that label on it, will help the more senior faculty that are not really sure what palliative care is or who equate palliative care with hospice to know the difference. Then how do we get our more senior faculty to adopt them? Of course, there's courses just like this one. Encourage people to go to the AUA and go to the QI Summit as part of the AUA meeting in Las Vegas if they're going. Your home nursing, PT, OT consultants, I'm sure would be glad to come to your grand rounds and give talks on what resources they have. The gerontologist at your facility, I'm sure would be glad to offer courses there, give a lecture, and of course your social workers who are probably stretched thin, just like the rest of ours, but would be happy to talk to you about what options. My favorite is actually to assign educational tasks. Now, being the boss, I can do that. That's a little harder to do, but for a lot of you, but if you get the faculty member that's maybe resistant to looking at palliative care as an alternative for patients, maybe have them host a journal club on palliative care, assign the residents some reading on that topic, have them give a lecture, and maybe have one of your residents do a QI project, which they're all supposed to be doing on palliative care topics, and ask this faculty member to supervise that project. All of these can be helpful and maybe encourage those faculty members to be more accepting of palliative care as an important component of urologic care. Once it's accepted, the role of palliative care in the education of residents and fellows, as was mentioned earlier today, is important and an ongoing discussion, and should be a broader component of our education of these individuals. It's an area of care ripe for excellence. So if we've got our more senior faculty that may be rather stagnated in their career, maybe like the woman in this picture who has no business doing big oncology cases anymore, that may be something that they can do to give their practice more longevity, to fight burnout, give them some new topic to learn. So there are many ways that we can integrate palliative care into the practice of our more senior faculty without offending them. We don't want them to think that they need palliative care, of course, but to think of a way that they can integrate it into their practice, that can be a component of practice maybe that they are focused on and can relate to patients better, and hopefully provide education and support for the training programs as well. Thank you very much for the invitation, and I look forward to hearing some of your questions.
Dr. Terrace, that was awesome. And hopefully now we can get everybody back for the Q&A. We have several questions. Dr. Hauser, the first one is to you. We got a question about, with everything else that urologists need to learn during training, how do we figure out when social services and nursing services can supply important care with the urologist backing them up?
Thank you, John, for passing along that question. And I think it gets at this teamwork issue, which I know is an important one for urologists and it's important for palliative care. I do think we need to think, as we think about teamwork, how we apportion tasks. And a lot of palliative care tasks, I think, can be extremely competently done by nurses and social workers and others on our team. So that's the first point, to kind of recognize that. The second point, though, is there is something about the doctor, your doctor, a doctor, emphasizing the importance of something that is meaningful to patients. And I'm remembering some data from a colleague named Far Curlin. Far is an internist ethicist who does a lot of work on spirituality. And Far did a series of studies a while ago now around what patients want around spirituality from their physicians and other people on their team. And basically with spirituality, they want their physician to recognize its importance and to ask a question or two. They don't want him or her to take all the time in the world. They don't want him or her to subsume the role of a chaplain, but they want them to recognize the importance and to sort of begin a conversation. So the parallel I'm drawing for palliative care and urology might be that a urologist isn't going to do all the hospice referrals and even maybe all the emotional work of palliative care. But having a urologist start to engage in what we're calling primary palliative care, start to engage in a conversation about what a lot of the panelists have already talked about. What's important to you? What's most meaningful to you, Mr. Fill in the blank, Ms. Fill in the blank, I think is really important and need not be time consuming. All of us are busy. Urologists are really busy. Palliative care doctors are really busy. Social workers are really busy, et cetera. So we need to find a way to do sort of appropriate triage of role. But the recognition and the initial exploration, I think, may be very meaningful coming from a urologist.
Yeah, I agree with that. I think Dr. Hauser brings up a great point about building out roles and understanding how to start, initiate that conversation, and then recognize that the reason we work together as teams is because we can refer and we can integrate really our colleagues within our own care teams, as well as outside the traditional confines of a urology practice. I think for early career faculty, that emphasis on building a care team that has buy-in, that understands these primary palliative care principles is really key, because as a urologist, I can start that conversation. I can elicit some of that quality of life discussion and help the patient to navigate toward a treatment option or options that are most aligned with their priorities. And then members of my care team can follow up with this is what the palliative care plan might look like, or here are some additional folks that will be helpful to extend this conversation and continue the conversation in the plan. So I think that building a care team that is focused on these principles that we've been talking about today helps to elevate the quality of that conversation, so that it doesn't all rest on the shoulders of one person, but in fact we can synthesize what we talk about and support each other, and of course with the patient at the center.
And I'll echo that you mentioned, Dr. Hauser, about the issue of time. And I've heard this quite a bit in terms of, we already have so much to do in our clinic, in our very short visits, time is of the essence. Adding one more thing I have to cover is a problem. But research has looked at this, and people who implement palliative care skills in their conversations with patients actually save time, and they've actually shown decreases in the amount of time needed to get patients to conversations that are fruitful in clinic. So I think that's also something that is beneficial to us to know.
John, may I add one more quick thing? I'm just reacting to that comment from Dr. Philippou. I think it's a really, really important comment. The other thing that I would add, I think builds on something that Dr. Terrace mentioned, that these conversations can be very meaningful. They're hard. I don't want to say they're easy, and I don't want to say it takes me like sometimes sort of get ready and all that kind of stuff, as we've heard, but they can actually be meaningful for a urologist and a patient to have. So I don't think it's all drudge work, if you will, to have these kinds of conversations. So maybe more efficient and may also be meaningful.
I had a question from the audience, and I'm going to parse it out into a couple of the different concepts in the question, and then we can come back to some of the other concepts. But we do see a lot of emerging literature around financial toxicity and the financial burden of the treatments that we are giving to patients. In terms of the financial impact of end-of-life care, is that something that is enveloped within this discussion? How do you navigate financial discussions with patients? I'm going to direct that first to Dr. Philippou, just because I know she's done some work in financial toxicity, and then see if it bounces off anyone else.
Yeah, I think Dr. Huger, you can certainly help with this as well, because you've done a lot of work looking into kind of the utilization of healthcare at the end of life and how that plays out. But I think it's important to consider, end of life care is expensive, and we already know that there's a shortage of caregivers and facilities and patients able to access the support that they need at the end of life. I think palliative care it should be kind of talked about as a piece of that, but certainly not all of it. And I think that providing patients with the skills that we can in a primary palliative care delivery setting could actually help with some of those, end of life costs, because, quality and meaning would be more kind of parsed out instead of these high utilization, high cost things that people are currently experiencing at the end of life.
Yeah, I agree with Dr. Philippou's statements. Trying to understand where patients are coming from is really important to mitigating financial toxicity, but the healthcare utilization and cost impact of palliative
The alligator ate his microphone.
leadership. I think it's a very compelling argument for increasing these resources. But may not necessarily, impact patients in the way we think. I think the people that are most impacted by the excess costs are the hospitals and administrators and, and chair people that have to, balance the books.
Dr. Nagad, we had a question to you about the current state at UCSF, both in terms of the training that you currently get in residency and also clinical care-wise. How do you see palliative care being integrated or not being integrated into the care of the patients that you treat at the different settings at UCSF?
Yeah, thank you. Thank you for the question. At UCSF, we cover different hospitals that serve pretty different patient populations, which I think is similar across the country. We have a VA, which serves often older patients who have a lot of different comorbidities. We have our county hospital, where a lot of underserved patients are seen and cared for. And then we have our academic centers. UCSF has different hospitals where that's more of the tertiary and quaternary care centers. And so I think that at all of the sites, palliative care is very important. And it's a part of our day-to-day decision-making, when deciding, who to operate on, who not to operate on, who to offer different treatments for. And then also, we're very lucky at UCSF. We have a fantastic palliative care team. So I think there's a lot of opportunities for residents to be able to work closely with them in a very immersive fashion, just given different time constraints that we do have as part of our training, so that we can better learn how to approach some of the more difficult conversations that are very meaningful, as Dr. Hauser had mentioned. So I think there's, to answer the question, I think that the way we practice palliative care as residents is especially important in the clinic setting, where we are seeing new patients with new cancer diagnoses or other diagnoses or chronic quality of life issues that are affecting them. And so we start to engage in some of those discussions, but where I see the most opportunity for growth is in working more directly with our palliative care specialists, so that we can grow those skills and figure out how to best tailor them for our practice with all the different patients we see and the different conditions that we manage.
And I might add that the education and the growth of our understanding of these principles, so that we can then put them into practice, doesn't necessarily have to be onerous or require a year-long fellowship or extensive training. I think that for our trainees, being around and modeling and being mentored by clinicians who integrate quality of life discussions and are able to navigate between those discussions and the usual clinic visits that we have, clinical encounters, I think does a tremendous job of helping them to better understand how they too can integrate palliative care principles, regardless of where they practice after training or what their clinical focus is going to be. And certainly I know that as I build my practice, I'm trying to be a model and help my trainees see what that discussion can be, and that it doesn't have to be onerous, as Dr. Hauser has mentioned, that it can be meaningful. I'd be interested in hearing from the trainees on the panel about whether this type of role modeling or mentoring, just by being around that these types of examples, has helped them to better integrate those principles in their care.
I think absolutely. As a young trainee myself, oftentimes when I'm preparing for clinic, I will see patients who I know I'm going to have a complex discussion. So I'll ask our attendings, how do you approach this conversation? How do you go about this? And there's so much invaluable learning to be done there in terms of how to have these conversations well, where the patient is really put at the forefront and their needs are really being met, so that both the patient and the provider walk away from that discussion really feeling like the patient has been cared for, and that shared decision-making is really at the forefront of that. So I think that's a fantastic point.
In addition to that, I've learned a lot just by keeping my ears and eyes open. I try to maintain a day book. Usually things I hear just go into the notes section of my iPhone, but these types of clinical pearls or way of communicating with people, come in passing, and unless you capture it and write it down, you're going to forget it. And just like having certain moves in the operating room when you encounter a difficult situation, these phrases or approaches can have a similar impact in the clinic when having these discussions.
And I think part of that mentorship also is mentorship from the collaboration between urology and palliative care. And I think that is also something that we need to actively and purposefully build up, because I know Dr. Huger and I have had this discussion before of, finding ways to integrate palliative care in our tumor boards or in our multidisciplinary discussions, so that at the very best, obviously the patients are getting this multidisciplinary care, but at the very least, the providers are being able to ask these kind of offline, consult type questions about how do I deal with this, or how can I manage this? How can I talk to a patient about this, and gaining experience from that.
May I add something? One of the most fulfilling things that I get to do as our fellowship director in palliative care is I get to welcome visiting fellows from other specialties and residents. So currently in palliative care, we have GYN-ONC fellows, we have ONC fellows, we have interventional pain fellows, we have pulmonary fellows. Now, note, there are no urologists on that list. Now, this is making me think, and this is good education for me about how to welcome urologists and other surgical subspecialties. But to the point of sort of, I hope, mentoring and role modeling that we hope, we don't know, by the way, but we hope will have implications down the road. I think the opportunity, because I learned from that, and I hope my colleagues learn from that too, the opportunity to have a urology trainee, a urology faculty member, a GYN-ONC faculty member, a GYN-ONC fellow, rotate with a palliative care team. I love Dr. Hugar's idea of certain moves in the operating room and the parallel in palliative care. That makes me smile to think of myself as doing something like a surgeon. That's awesome for me. I think really valuable. So I would encourage, for example, the practical point of what I'm saying is that any urologist, whether he or she is a resident fellow or even a faculty member, might approach your local palliative care doctor. We'll call him Dr. Smith, or we'll call her Dr. Jones, and say, hey, I'd like to spend an afternoon with you once a week. Or if you have more time, I'd like 2 weeks. I'd like 4 weeks, and see what they say. And I think that could be a really valuable sort of small and focused intervention.
Dr. Huger, before we wrapped it up, there was one question that Dr. Hauser posed that we wanted to send your way about outcomes. If we think as a urologic community, if we wanted to implement something, what would be the most relevant and trackable outcomes that we would want to consider?
Yeah, that's a great question. I think, determining patients' preferences up front would be really important. And then, correlating their disease trajectory or, what happens at the end of life to their preferences before we see them in clinic. I think that would be a big one. And then just tracking distress, like with various instruments like the distress thermometer or the Edmonton symptom scale, and just tracking that over time. Because if we spend the time to really get down to the issues that's really impacting patients the most, the end goal, whether it's having a discussion or taking out an organ or a stone, the end goal is to decrease distress, whether it's physical or emotional or social, what have you. So those types of survey measures, I think, would be important patient-reported outcomes to track over time.
Absolutely. And I think as our boss, Dr. Lidwin, always taught us, that patient-reported outcomes not only are often more meaningful, they're much easier to track in real time than other outcomes, especially in things like prostate cancer that take so many years to mature. So I think that's a great point about that. I think before I pass it off to Dr. Gore to finish us out and do the final mic drop, we just want to say a huge, huge thank you to all of the panelists. It's such an honor to get to work with you. We are fully aware what an immense amount of time it takes to put together the incredible and meaningful and thoughtful talks that you've all put together. And in addition to this wonderful, wonderful summit, we can't wait to work with each of you on the next steps and on actually doing the stuff that we're all bloviating about. So really, really massive thanks for all your skill and energy and time that you put into these talks. And we can't wait to work together. And then to our fearless leaders, Dr. Gore and Dr. Nielsen, just a personal thank you. Dr. Nielsen, it's been such a treat to work with and learn from you, and I can't wait to continue to do that in the coming months. And Dr. Gore, you know, you've been my idol since I was a third-year med student, and to see the impact you've already had on our field is just really humbling to all of us who are kind of making our way through. And finally, to Caitlin and Emily and Karen, who have really put in the most amount of work into this conference. I'm so apologetic that this is by webinar and in person, because we basically took your already Herculean amount of work and probably multiplied it by about 10. The fact that everything has gone so seamlessly is a credit to the many, 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 many hours that you have all put into making this successful and helping us corral everyone. And we can't wait to work with you for the September summit. And also on a personal note, thank you for letting me use my older photo when I was much younger and more spry. Dr. Gore.
Thank you so much. And thank you again for everyone. I want to echo everything that John said. You know, it's fun to do good things. It's even more fun when you get to do it with your friends. I want to plug our in-person summit on Monday, September 13th. Importantly, this is the last day of the AUA, but it does end in the morning. So hopefully everyone can make it to their flights soon after the summit is over. This is going to be an action-oriented summit. You know, the goal is to take a lot of the concepts we've been discussing in these two webinars and figure out how we can, in an action-oriented way, implement some of these concepts to improve the delivery of palliative care in the field of urology. We do have some funding from AHRQ to support travel stipends for residents and fellows, and the deadline is only a week away. It's a low burden application, and we would love to see as many of you there as possible. Thank you so much for your investment in these webinars. Thank you for your great questions. Thank you to all the panelists, and I hope everyone else has a wonderful day.